we completed the survey across European investigators in order to understand which is the uptake of genomic signatures in order to decide whether to give chemotherapy or not in the adjuvant setting in patients with early breast cancer. What we discovered is that finally there is a lot of pickup of these genomic signatures in order to select patients that should be candidate or not to chemotherapy in the adjuvant setting. And following the final presentation of the ERICS founder trial, of course, the main use of genomic assay is for patients in the postmenopausal setting, where we have a clear benefit from genomic signatures to select those patients who are candidates to chemotherapy versus those patients who are candidates to endocrine therapy alone. Also, in the final analysis of ERICS founder, low risk and intermediate risk for patients with postmenopausal status, it's a clear indication to endocrine therapy alone. For premenopausal patients, unfortunately, a low risk or an intermediate risk can be considered still an indication to chemotherapy. From our survey, of course, there was also the perception that in the future, specific genomic signatures can be used also in the context of the metastatic setting, but mainly also for HER2 positive disease and eventually for triple negative disease. We don't have, of course, so many data available in this setting, but we saw clearly that in the San Antonio Breast Cancer Symposium, some subgroup analysis using a molecular intrinsic subtype can predict potentially benefit from agents like CDK4/6 inhibitors also in their HER2-enriched population. So our survey finally confirmed the role of genomic assays as prognostic signatures to better identify patients in the pre- and the postmenopausal setting that are candidate to chemotherapy and opened the window for the use of those genomic assays also in the metastatic setting.